Hello, my name is Dr. Heather Johnson, and this is a screencast presentation on range of motion, factors, assessments, and norms. What is normal range of motion? Do you have normal range of motion? Let's check your shoulder abduction. Place your hand to your side, externally rotate your arm, and raise your arm as high as you can above your head, keeping it in the scapular plane, which means keeping it flat against your scapula. How high can you go? How do you know if your range is normal? Today's learning outcomes include considering influencing factors, measure and assess range of motion, use provided resources to identify, interpret, and compare range of motion. Range of motion, abbreviated ROM, is the amount of movement that occurs at a joint. It's defined as the measurement of motion available, or the arc of motion available, and can be measured with a goniometer. It's contraindicated to measure range of motion on a client if they have dislocations, fractures, they're post-op, they have an inflamed joint, subluxed joint, hematoma, marked osteoporosis. When in doubt, ask the physician or the surgeon if it's okay to assess range of motion in your client. Joint motion is influenced by several factors: client factors, psychological factors, environmental factors, skeletal factors, and methodological and measurement factors. Client factors include a genetic predisposition to being flexible or not flexible, which we call hypermobility or hypomobility. Client factors also include health status, if the client has joint disease or an injury, edema, pain, scarring, or adhesions, or muscle shortening from non-use, which we call contractures. Client factors also include age and gender. Women are statistically showing a wider range of motion compared to men. If you look at the statistics from the CDC shared in week 2 of your resources on Canvas. As we get older, collagen, elastin, and hyaluronic acid decreases, affecting range of motion in the older population. Although, when given an exercise program and actively engaging in ADLs, clients do show that they can have increased range of motion even though they are the older population. Pain can also influence range of motion, and pain can be caused by a condition worsening, acute inflammation. Your client could have an injury, a bone injury, or tendinitis. Psychological factors include the client's emotional state at the time. Are they anxious? Are they fearful of movement because they're afraid of pain? Many clients may do guarding, which is a tightening of the muscles to protect against injury. If your client has cognitive impairments, that could affect their ability to follow directions. And all of these psychosocial or psychological factors can make range of motion assessment results invalid. Environmental factors include temperature, the number of people in the room, the noise level in the room, and the time of day. Time of day can especially affect range of motion in people with chronic conditions like rheumatoid arthritis, Parkinson's disease, and multiple sclerosis. Skeletal factors can affect range of motion, such as impairments of the muscles, nerves, or at the joint level, impairments at the connective tissue level, which includes fibrous tissue, cartilage, and bone, which are all affected by the levels of elastin or collagen in them. And your methodological and measurement factors can also affect your range of motion results and affect your validity and reliability. The goniometer is the gold standard for measuring range of motion, but you can see variability in measurement for range of motion in your client with your goniometer placement. and if you do not use consistent definitions of range of motion. If you do follow consistent definitions of range of motion, you are placing the goniometer at the right axis and keeping the arms of the goniometer within the shafts of the bone, you will generally see within a 5 plus or minus degree accuracy compared to other readers. You can use screening to assess range of motion initially with your client by doing a functional assessment. See what your client is able to do. You can ask your client to reach behind their head, reach behind their back, pick up items off the floor, reach for an item above head, don a pair of pants or socks, and if a deficit is noted, proceed to the goniometer assessment. But a screening is very helpful for assessing multiple joint movements or combined movements and help you determine if it's important enough to move on to a more standardized assessment. So for assessing range of motion using goniometry, you would use a universal goniometer, like the one that was recommended for you to purchase for this class. But goniometers come in all shapes and sizes. Here's a very large goniometer and a very small goniometer. A goniometer is a simple uniplanar protractor to measure the angle of the arc of movement. You can get one that's in a half moon shape. You could get a metal quarter moon shape that's used for measuring flexion and extension of the knuckles and the wrist. So typically the way goniometer works is one arm remains with the stationary part of the body and the other arm follows the movement of the other part of the joint. Why don't you use a goniometer to measure the range of motion for your shoulder abduction so we can get a more standardized understanding of the range of motion of your shoulder? Pause this video, and after you measure your range of motion at your left and right shoulder, post it to the Google Docs link that we have on Canvas under resources. And then we can gather the data from everyone in this class to calculate a norm for abduction range of motion. There are 3 positions that you would have a client be in to assess range of motion. Seated is the position for most range of motion assessments, and ideally your client would sit in a chair without arms, but you could also have your client stand for range of motion assessment to assess trunk movement, ankle plantar flexion, and ankle dorsiflexion, or you may have your client in supine to assess hip flexion and knee flexion. The way you measure range of motion is you identify the location of the joint axis, which you may need to do through palpation for a bony structure or prominence. So make sure that the area of the body that you're assessing range of motion is uncovered. You place the axis of the goniometer, the rivet, at the joint axis, and make sure you maintain the original position of the goniometer throughout the movement, keeping the stationary piece in place. Keep the goniometer arms aligned to the body segments. So if you're to assess abduction, you would keep the movable arm along the shaft of the humerus. Now, it's important to note if the range of motion limitations in your client are when you perform active range of motion or passive range of motion. Active range of motion is when the client moves without your help, and passive is when they don't do any of the manual work and you manually move them through their range. If the client is having a harder time with active range of motion, but you do passive range of motion and find that they have full range, then the problem's more likely to weakness. When you're performing passive range of motion for your client and you're moving the joint through an arc of movement, at the end of that range of motion, you will feel a resistance, and that is called the end feel. A normal end feel will depend on the type of joint that you are assessing. So you may feel a soft end feel when you have soft tissue touching soft tissue, such as when you have elbow flexion, you're having two groups of soft tissue touch one another, or knee flexion, or CMC thumb flexion. A hard end feel would be something that you feel with bone against bone, like in forearm pronation, PIP flexion, elbow extension, MCP flexion of the thumb. Most other times with range of motion, you'll be feeling a firm end feel, which is more like a stretch, a muscular stretch, a ligamentous stretch, a capsular stretch. An abnormal end feel would occur sooner or later in what we would consider normal range of motion. It would feel boggy, and or you would feel the wrong type of end feel for the type of joint. So for example, a joint that you may be expecting a soft end feel, where you're feeling a hard or firm end feel, could indicate an abnormal or pathological end feel. Where you might expect a hard end feel, if you're feeling a soft or firm end feel, this would be typical of an abnormal or pathological end feel. Other abnormal or pathological end feels include spasm, capsular end feel too soon in the range of motion, a springy block, or muscle guarding. Abnormal limitations in passive range of motion could indicate any number of things, including destruction of bone and cartilage, bone fractures, adhesions and scar tissue, muscle atrophy, also called hypertrophy, muscle tears, ruptures, denervation, pain, psychological factors, edema, or neurological impairment. Any of these you would want to report to the physician if they don't know already. The way you interpret range of motion results is through comparison. You would compare measured range of motion values to norms. So when you measured the range of motion for your own abduction, I want you to look at the link, the CDN links that I provided on Canvas in the week 2 of your materials and resources, and see if the number you found is comparable to the norms for your age. Is it? Well, then you would have range of motion within normal limits, also abbreviated WNL. You could compare an uninvolved joint with the involved joint. So let's say someone had a shoulder replacement surgery. You can measure the range of motion on the side with the surgery, provided you have permission from the doctor, and then compare with the uninvolved side to see which is how they're progressing with their recovery. You can also compare range of motion with functional range of motion requirements. Occupational therapists really aren't very concerned about range of motion within normal limits. We're really concerned more about how limitations will impact clients' abilities to engage in meaningful occupations. So it's important to know what type of range of motion your client may need to perform simple day-to-day tasks. And if they do have the range of motion needed to perform basic self-care skills, then we might say that their range of motion, if it's not within normal limits, could be within functional limits, which is abbreviated WFL. In summary, range of motion is the arc of motion that occurs at a joint. Individual factors can influence range of motion at a joint. The structures of a joint influence the end feel. Range of motion measurements will be more reliable and valid if you use a goniometer, a consistent clinician, consistent test procedures, and consistent environmental conditions. Now that you know all about range of motion, I look forward to seeing you assess your own range of motion of your volunteer in your own household. Make sure that you measure abduction range of motion and submit your results to Go React so I can see a video of your techniques and tell you what I think. I think it'll be really fun and you'll do well. Just make sure that you keep that axis at the axis of the joint, that you keep the arm in the stable position and move the other arm along the shaft of the other joint. Please contact me if you have any questions. Good luck.